Hello, everybody. Happy Friday. We are here with Dr. Esther Bianchini. Thank you so much, Doctor, for being with us today.
My pleasure to be here.
So, Dr. Esther Bianchini received her Ph.D. in Science, Experimental Physiopathology at the Medical University of São Paulo. Currently, she is in the chair of the Speech Language Pathology Department for the Brazilian Sleep Society. Dr. Bianchini teaches students in the Speech Language and Hearing Postgraduate Program. She has published many articles in journals and congressional meetings, as well as books and chapters in books. We are so honored to have her here. Dr. Bianchini, thank you so much for everything that you have done for us so far. We would all, myofunctional therapy world would not be here if it wasn't for so much that you have already done. So thank you so much.
So I'm very honored to be here, and I would like to thank you for the invitation to be here to speak with this special group, a special team that is very interested in our work from Brazil, and also that are trying to make the better quality of life for all the patients that have some problems. So thank you so much for this opportunity.
Of course. So today we're going to talk about sleep disorder breathing and when orofacial myofunctional therapy can help. And I already did a little bit of my intro, but I'm going to read to you guys what I wrote. I would like to start by thanking you and all of the wonderful Brazilian speech pathologists who have done so much research in the field of orofacial myology. You guys are referenced all over the world. Would you tell us a little bit about how speech pathologists in Brazil become orofacial myologists and specialize then in sleep?
Okay, it's interesting to talk about this because we have many differences around the world in this matter. In Brazil, the profession, the speech, language, and hearing science was recognized in 1981, 40 years ago. This specialization was recognized in 1996. Only 4 specializations at the beginning: language, audiology, voice, and orofacial motricity. That's the name. So, since the beginning of the specialties in Brazil, our area was included as a specialty. Nowadays, we are almost 45,000 SLPs in Brazil, and we have 14 areas of specialization recognized and accredited by the Federal Council of Speech, Language, and Hearing Science. Orofacial motricity, our specialty, is the third one with bigger number of professionals. And in this specialty, SLPs enables and rehabilitation functions related to breathing, sucking, chewing, swallowing, facial expressions, speech articulation, rehabilitation after orofacial and oropharyngeal surgeries, temporomandibular disorders, sleep disorders, breathing, facial paralysis, and there's a very big list. At the beginning, when we have only 4 areas of specialty, dysphagia was included in our scope. It's very important to, this point is important to explain how the first studies about sleep and sleep disorders breathing, especially sleep apnea, began. So, in this specialty, at the beginning, we also work with dysphagia. And dysphagia has a lot in common with sleep disorder breathing. So the first studies began with Kátia Guimarães in 1999. This first study is published in a Brazilian journal. And the reason, so at that time, the reason to think that our work should be effective to sleep apnea was related to our work with dysphagia. The same structures, the same place, and in dysphagia, the aim is to allow the apnea, the swallowing apnea, which protect us from pneumonias. So to swallow with security, we need swallowing apnea. So it's a paradoxal because working with dysphagia, we did many things, exercises and functional uh, training to produce the collapse, to close the airway, and to allow a safe swallow. And because we work with that, we think that we could do the same, but to establish a more convenient mobility, endurance, and tonus of this area to avoid snoring and sleep apnea. So there were a lot in common. In 2005, Kátia Guimarães began her doctorate at School of Medicine at the University of São Paulo with Dr. Geraldo Lorenzi, a pneumologist that always believed that it should be possible. In her doctorate, she developed the first controlled and randomized study checking if the Orofacial Myofunctional Therapy at that time, including, I'm not sure, but I think 12 exercises or 14, I'm not sure, plus functional training, especially with chewing and swallowing. And then they compared one group that this training and the other one that we call placebo. And the results were very interesting, and she published that in 2009 at the, let me see, the American Journal of Respiratory and Critical Care Medicine. After that, many other studies are being developed, especially with Giovanna Giafferia from Unifesp, University of the State of São Paulo, School of Medicine also. Fabiane Kayamori from University of São Paulo with Dr. Geraldo Lorenzi, Vanessa Ieto, in the same school and with the same pneumologist, Dr. Geraldo, as the orientator. So that's how it began here. And then all these studies have been published in a very high impact journals, and still now there are a few studies, only a few studies that are really randomized and controlled. And this is a big problem because we can do a timeline showing all these studies developed especially by Brazilians. We have then we have a group in Italia with Dr. Maria Villa, and also in Egypt. I am not able to pronounce the name of the authors. And all the systematic reviews and meta-analyses that we have today showing the positive results of our work with sleep apnea and snoring always include these first studies. It's a pity that nowadays, especially in the last 2 years, we had no new study published except for systematic reviews and meta-analysis and reviews. Okay, so we need new studies.
Definitely beautiful. Very, very good. We have some amazing people watching on Facebook. And if I'm looking to the side, because I have my phone here, if somebody asks a question, I'll be able to bring it over to us. But we have Lael, Chelsea, Beth. Thank y'all for watching. At the end of today, I'm actually going to raffle our robes, so stay tuned. What are some phenotypes and genotypes of a patient who might present with obstructive sleep apnea? Question by our friend Marielle Bussi. Thank you, thank you.
And you mean in general?
Yeah, general. Some phenotypes of somebody that,
well,
come to our office and they.
First of all, a small consideration. We have some differences between phenotypes and genotypes. Okay, so phenotypes are the ones that you can see, you can check. Okay, and some of them depends on the genotypes. So, for example, maxillomandibular deformity. Okay, so it's a phenotype, but depends on the genotype. Okay, it's not simply acquired during the growing or with any kind of dysfunctional pattern. It's really directly related to genetic. And the main phenotypes are male, obesity, and it's interesting because all the articles mention that it's much more frequent in men, but after the menopause, women have almost the same index of risk for sleep apnea. And we have as a phenotype medical conditions, for example, diabetes, something like this, age. There's a friend of us that is a doctor that said, first we thought that we are born, we grow up, we got aged, old, and then we snore and we have apnea. We hope that, yeah, because it's true. With age, muscle fiber changes, not only the airway muscles, but all of them. So, and elder people cannot, for example, run as fast or as uh, a young as a boy. So age and the bone, the osseous bases, breathing conditions, especially about the nose and some obstructions, smoking, alcoholic, how do you say alcoholism?
Alcoholism.
Alcoholism. And also as a phenotype, some kind of familiar history. Okay, so these are the main phenotypes. But what we see is that many teams are studying a lot about obesity nowadays. Okay, so obesity is really
Especially
terrible.
in the United States.
Yeah,
I
and
mean,
it's
everywhere.
common in the whole world. So these are the general phenotypes. For if we think about which of these phenotypes are especially related to our work with orofacial myofunctional therapy, we can say breathing conditions, we can say uh, Osho's, oh my God, maxillomandibular proportion. We can say some habits like oral breathing as a habit. And we can say the changes in these muscles that are involved with the airway and swallowing patterns.
Very, very good. I have to tell you something now. If you would like to screen share, you can do it now. I figured it out.
Okay,
It was in
okay.
my hand. If you would like.
Okay, not yet.
You just
Yeah.
let us know. But now you're able to do it.
Okay, thank you.
Um, so does anybody so far have any questions? I do have Devani asking on Facebook. She said, "Hi, is there any way I can access the exercises mentioned in these studies as an American speech pathologist?" Everybody always talks about myofunctional therapy exercises given to patients who have sleep apnea or sleep disordered breathing. Uh, Talking about the exercises the Brazilians give, that those are the right ones, those are the best ones, that you guys have the research to back it up. That's always talked about here a lot. So I think that that's where the curiosity is.
And I think that the reason for this is because only these exercises proposed initially by Kátia Guimarães and Vanessa Ieto and Giovanna Giafferia were submitted to a randomized study. So we have nothing else. Unfortunately, we have nothing else. Even, for example, in the last 2021, I don't know if there is something more recent, but the last systematic review that I've read, they found 11 studies elected, and 7 of them were Brazilian studies, and the others also you applied the same exercises. So they how can I say, they replicaram o estudo, they
They re-
reply.
they you know what? This is so funny. I am like the worst translator. I know Portuguese and I know English, but they redid the study. They
Yeah,
copied. They did the same exact study again.
and also in 2015 Vanessa Ieto uh, appeared at in American television. It was, I don't remember, but it was a program, and they showed the exercises in your television. Okay, so
Wow. Yes.
yeah,
So we will try. Is there? So that's a study. Maybe we can try to have access to the study and we can post in our closed group.
yeah, I
If
can
I
send it to you. But um, uh, I'm concerned about this. I don't know if I can talk about this right now
okay,
or
not
could
a
be
problem.
later.
Yes, but
But
I know that that's always what everybody.
you know, in 2000. Do you have the expression, I had already seen this movie in English? Do you say something like this? Like, I know what will happen. In Brazil, we say, I had already seen this movie. So,
I've seen this movie before.
yeah, in 2000, really 2000, for example, here in Brazil, we had many studies about temporomandibular disorders and the possibility of help of working with this with orofacial myofunctional therapy, but it was something very specific and with a very important criteria of eligibility for working with these patients that has pain. And it was a boom. I have a book, for example, it's a 400 pages book about SLP for TMD.
Mm-hmm.
But after 10 or 15 years, we lost our place. And why? Because people think that doing exercises means a treatment.
Mm-hmm.
And I'm afraid that the same will happen with sleep apnea. Because in Brazil, for example, to work with this, we have to be SLP, we have to be specialist, and the Brazilian Sleep Society accredited the SLP in sleep medicine since 2014. So we have to do courses to learn to work with this and to be accredited from Brazilian Sleep Society. We have to do a test, a very difficult test, a written test, and then a practical test with 2 cases, 2 clinical cases. Only after that, if approved by 3 specialists from Brazilian Sleep Society, then you are accredited in sleep medicine.
Wow.
What happens everywhere, including Brazil? We have some apps with exercises.
Oh.
We have, excuse me, but in the United States, everybody think that all people can do exercises. And what's the criteria to choose the exercises? Oh, that study showed these 6 exercises. Let's do these 6 exercises. Remember that it means research. When we are talking about research, when we are going to publish a study, all the subjects, all the participants have to do exactly the same.
Mm-hmm.
So if the tongue is big or small, with good tonus or not, the exercise will be the same because it's a research. In real life, in clinical approach, it's not like this. Or at least it should not be like this.
Yeah.
I don't know how it works in another country, but in Brazil, we can, the SLP are the professional to do that and only this. And we have the ability and the scope of diagnosis. We can ask exams, we can analyze and interpret exams. We decided if this patient is a patient for OMT or not, and we encaminhar, we
can
derivate.
send,
Yeah,
refer.
we refer this patient according to what we found. So just a small example. If the severity of the sleep apnea is so high,
Severe.
it's not a case for orofacial myofunctional therapy. Okay, we can reduce, you can get it better. Of course, we do. But if the patient has an index of, for example, 70, it's severe. If we can do a very good work and reduce 50 or 60%, he will be still in the same patamar, severe. So it was 70 and now is 30. Okay, severe and severe. Okay, risk of cardiometabolic problems, risk of death, risk of accidents while driving or anything like this. So I am very I worried about that because everybody says, "Oh, orofacial myofunctional therapy came to definitely solve this problem." Nothing is definitively nothing. Even
Nothing in
surgery.
life.
Yeah, even surgeries. What we can do better for these patients which are not eligible to OMT
Eligible.
is to decide with the multidisciplinary team what which treatment is the best. So, for example, I don't know if all of you are dentists. We have the mandibular appliance, mandibular device, the advanced mandibular.
The mandible.
Yeah. The results in the researches are very important. It's like the it's not gold standard, but it's gold standard is CPAP. But we can see many fantastic results. But if you have the oropharyngeal muscles with problems, the patient will not be able to have the benefits of this appliance. So in this case, we can work together and then the patient will be able to accept the appliance better. The same to CPAP and the same to orthodontic surgery, for example, that they are doing the maxillomandibular advancement as well as maxillar um, maxillar
Expansion.
surgical expansion.
Yes. MSc or MARP. I'm doing that.
Oh, and it really
I'm
works.
starting in 2 months.
It really works, and sometimes more than it should. More? What do you mean? You cannot never incapacitate your patient of having apnea. If you do, he will never have apnea, which means aspiration, dysphagia.
I see. So you cannot prevent your patient from having apnea at all because apnea is a natural
Protection.
of our body.
Yeah, you need this.
Okay.
This is the
That
first
makes sense.
condition to swallow, to have a safe swallowing pattern. Okay, and I have many patients after orthodontic surgery with this problem. Okay, then has no apnea now, has dysphagia and repeated pneumonias and risk of death.
Wow. I am so glad that you are opening the eyes, and there's so many people watching it.
Everybody forgets, even to any force that you have to, you need a collapse, an airway collapse. For example, when you, como fala, fazer cocô.
When you gotta poop.
When you gotta poop, you need to stop breathing. And if you are not able to do one upper airway apnea, I'm sorry, but to do the poo-poo, you have to do like this.
Wow.
Good. So wow. What I mean, there is no magical solution. There is not only one solution. And even when we decide in the team that surgical procedure or the advanced appliance or CPAP or are the indicated therapy, you have to plan. You have to plan very well your surgery or your device, your appliance, or regulates depression and try many masks for CPAP and so on, because there is no magic. And there is one point, for example, for CPAP that we have here, who have been studying many patients, for example, do not accept or they have low adherence to the CPAP therapy, and some of them really feels worse. They say that if they use the CPAP, the night is worse than without that. And we didn't understand. There are some studies, and we saw many patients using DISE, drug-induced sleep endoscopy, that this is my line of research with ENT team. And what we see is when you have the epiglottis with flaccid that has, for example, easily collapsed, then with the pressure of the CPAP, the epiglottis push it down, and the collapse is worse than without CPAP.
Wow.
So what I mean, we professionals that are studying the sleep, we have to join our interest and forces, and please do not try to do the other professional attribution. Do yours, and then we can work in a team. There are many professionals. Internet now is terrible because you can find everything. And we have many websites of dentists doing the exercise, like to breathe perfectly. Do this 1, 2, 3. Repeat it 10 times. 4 seconds. Are you kidding me? I'm more than that.
Exactly.
Okay. So here in Brazil, we have the possibility of doing the diagnosis to see what really, where is the problem, and it's very interesting. Renata, you can stop me, okay? Because as you see, even with my English, when I begin, it's difficult to stop. So
it's perfect. Please feel free. The floor is yours.
Yes, because there are something that I would like to call your attention to, né? And one of that are the evaluation criteria. You see, sometimes the tongue is big, sometimes the space is small, sometimes the exercise will work, but for what?
Exactly.
Will work for better nasal breathing during the day. Because especially if you are in a REM stage of sleep, you have no tonus in the skeletal muscle. So you can breathe perfectly
Wow.
during the day. Okay? It's quite different when you sleep, including the position. So it's interesting because everybody wants to teach exercises and everybody forgets to tell the patient, for example, the position to sleep. Many times we see positional apnea, and some of them in moderate degrees, which means if you teach your patient just to sleep
On the
um,
side.
on your
On the
side,
side.
on the side, it can be better. Another point, Renata, just for us to conclude this very long, we can stay talking about this kind of problems for days, but
Yeah.
something that I would like to is exactly like TMG, that everybody begins doing exercise without any sense, and then in some case it was worse for the TMG, and then nobody believes in orofacial myofunctional therapy for that anymore. And here in Brazil, they do, because we have small multidisciplinary teams. I have some patients that uh, were treated with maxillomandibular advance, and they didn't get better. And why? Because sometimes we forget that sleep disorders are, we have a lot of sleep disorders. Not everything is apnea or snoring. So nowadays, for example, I have a patient in my clinic that is somebody that was going to do this maxillomandibular advanced. He has Epworth scale of 19. The maximum is 20. So he really has a very bad quality of life. And with some, when he did the polysonography, for our surprise, he had um,
AHI.
it was not high nor moderate, it was
Mild. Moderate.
mild.
Low.
Yeah, mild. He had mild, but and then they decided to do that. And when I saw that, I told him, too mild, don't you think that this surgery is too much? Maybe you can try something before, and if it does not work, oh, I'm not going to use CPAP. Okay, so let's try something easier. And on the third therapy day, talking with him about generalities, he has a 2 years old boy. Her wife has depression and is not able to take care of the baby. And
Ah.
during the night, his son called him not less than 5 times a night.
Wow.
So we can do whatever we want. The reason is not apnea.
And he was about to get surgery.
Yeah.
Wow, that's me right now. Almost 2-year-old waking up at least 5
So
times a night.
ask your patient, listen
Wow.
the history of your patient. Take time to talk to him and try to discover the habits. For example, I have another one that every night he likes to cook, and he cooks drinking wine, and every night he drinks like half a bottle of wine. It will not work. Uh, our treatment will not work. It's CPAP. Why? Because it's the only thing that can hold the airway open if you drink every night before sleeping. So let's do what we are able to do.
Lyle saying we all need to be better listeners for our patients. That is so true. And I am so glad that you brought all of this up because, you know, we always keep going back to Brazil. Over there, you guys have to have 500 hours or 2 years of specialization in order to become a myofunctional therapist. Things are changing over here now because 28 hours, everybody knows that that is not enough. And some associations and some courses are starting to, you know, increase um, the time and the teaching, the hours, which is great. And it's going to take a long time in the United States before we have a federal board that can regulate everything that we are doing, to make sure that we can keep growing, and multidisciplinary approach is going to be a little bit easier then, because, you know, we all know that right now we walk into a doctor's office, we're my functional therapist, and it's a little bit more difficult. Thankfully, we do have some amazing dentists and ENTs out there that will work with us, um, after they see, you know, our results and what we see, our reports for the patient. But unfortunately, teaching wise, we have a long way to go in the United States still. But I'm so glad that you brought all those points up. Beth had thought about you when Dr. Esther was talking about positioning, sleep positioning. She always talks about that. She says, I tell people all the time that kids are not a sleep disorder, but a sleep disturbance. You have, yep, you have to consider circadian rhythm, jet lag, REM sleep issues, so many sleep issues. I actually just talked to Jen Varela today. She's a gentle sleep coach. She was last night with us on Clubhouse. She's going to help me get my son on a good schedule because right now we are waking up a lot. But would you like to share something with us?
Yeah, if possible. I was trying to find out here.
Yeah, I could see it when you opened it up.
Well,
perfect.
This was you know, we know today that sleep disordered breathing can affect the brain, not only in when we are sleeping, but it can cause some problems that stay with us even after the solution of the sleep apnea. And of course, today we have many exams, fantastic exams that can show all the structure, the airway structure, and of course that we would like to have a very large one. But it's not only this that I will share another one we have to consider the muscles. It's in Portuguese. I'm sorry for that.
It's all good.
So when we have a patient, we have at least to examine how the muscles are working, or the tonals, etc. When we talk about a very classic classification of that means a parameter to define sleep apnea, it's one of them. It's modified Malampati or Friedman tongue position. When we consider Friedman tongue position, we have to consider the tonsils as well. Okay, so Malampati, we don't have to consider this. We have to remember that Malampati's score has been used for many years to identify patients that have a risk of difficulty in tracheal intubation. And it was not like this. It was with the tongue out of the mouth to see if there are some space back. Then, to work with sleep apnea, for example, they changed it because during sleep, the tongue is not outside of the mouth, it's inside. Mm-hmm. So the instruction is swallow and open your mouth, or just open your mouth. And we can see this, for example, in a patient. Can you help me? Which score is this? Modified Malampati, we have 1 to 5 to 4. 4 mm-hmm. is the worst, okay? So 4, when you cannot see
anything,
the soft palate or uvula. So which score is this one? 4.
There's yes, it's completely. I can't see the soft palate. I can't see the uvula. I can't see anything in the back of the throat.
So it's 4, okay?
Yes.
Let's do Orofacial Myofunctional Therapy because it's not good. And now, better.
Oh, that's a 3. Yes.
It's not. Yes, it's almost 3 because we began seeing the arcs, okay? And now.
Oh, there you go. Now I can see the base of the uvula, so that's more of a 3.
Yeah, it's 2. And now?
That's a 1. That's a 1. Is that the same patient?
Yeah, it's the same patient.
So now what?
Is this different? Before therapy, and this last one after 3 months of therapy? I'm asking a question. Mm-hmm. No, it's not. Okay, it's during the evaluation.
Wow.
If you just ask your patient, open your mouth or swallow and open your mouth, the patient has no idea what is your intention. What are you going to look for? What do you like to see? Is something like telling you, jump. You can jump with 2 feet, but if the examiner, if the professional was expecting you to jump only with 1 foot, you did it wrong. But what's the problem? Nobody explained to the patient what we'd like him to do. So in my clinic and with my patients, we do this from the last 10 or 15 years. First, you ask the patient just to open the mouth. Then you tell the patient immediately, okay, nice, take a photo. Now, I would like you to open your mouth with your tongue resting on the
Floor.
Okay? And this is what he did. And then I said, okay, nice. Now the third picture is of your throat. I would like to photograph your throat. And then the patient did this by himself. And then I showed the patient. Then I opened my mouth and said, now let the tongue abaixo, above,
Below.
below
Mhm.
your inferior teeth, like this.
Ah, that's a great way to explain it.
And now you are going to pretend you are with sleep. You would like to sleep.
Sleepy.
Como bocejo. I don't know how to say this. Or
Yawn. It's called
yeah,
yawn.
yeah.
And let's click on.
And do exactly like me. And then the patient did this. Okay,
Wow.
so if the muscles are good, there is no need to evaluate a patient and do not give the information. And you can be sure. I should show a lot of patients like this. If the muscle is not good, if the coordination is not
Mhm.
good, or if there is no space, the patient is incapable of doing this at the evaluation
Mm,
process. Okay, then we can do it after 3 months. Okay,
wow.
then he can be elected to the therapy. So what I wrote this, but in chapters in book. My advice is when you are doing your evaluation, try hard. Be sure that your patient knows what you'd like him to do. Be sure that he will not do wrong because you did not explain. Okay?
Wow.
So we have also problems with this. For
Yeah.
example, can you see this? This is a girl that is trying to do the same. This is the evaluation.
Mhm.
You see that the tongue is like this? Wow.
Yes, a little wave, and everybody says that that dip right there, that means they have a tongue tie, right?
Yeah, that's my second concern.
Mhm.
Nowadays, everything is tongue tie. It's not tongue tie,
Mhm.
neither posterior tongue tie. The tongue is here, up, because she has torus. Can you see this?
Mhm. Yes.
So the torus is occupying the space
Face.
for the tongue.
Wow. Because of the Taurus.
Okay? So there
So
is no
her tongue.
problem with the frenulum. The problem is uh, torus,
Taurus.
bone. Okay? And
Thorax. Wow.
sometimes we work with electromyography. Okay? So you can see all of these are cases, for example, um, of evaluation procedure. So you can see that this guy, this is the maximum, and the tongue is
Mhm.
asymmetric. I tried to help him. Okay. So after working, he could do, but not at.
Ah.
Okay. So that's the difference. You can find when you have no possibility. You see here another patient
Uh-huh.
that has no, this is the first malampati. This
Uh-huh.
is the second, this is the third, and this is after I showed myself doing this. So this
Mm.
patient has no
Uh,
coordination,
mhm.
tonus, possibility of doing the same of the other one. So don't be
Wow.
afraid. If the patient has a problem, you can find the problem. Okay,
Beautiful.
that's it. We are doing many studies with we are doing many studies with drug-induced sleep endoscopy. We are
Mhm.
trying to understand the collapse, how the collapse works. And we already know that many times we are working with the tongue, we are working with the lips, and the collapse is with the velum. And the contrary is true also. And
Wow.
many times we have epiglottis collapse or orofacial myofunctional therapy. It is hard to help.
Wow. I had so many questions still, and guys, we are at our time. But I will ask one last one before we leave. I know everybody's loving this. This is something that is not taught anywhere here. So I am so happy that you're here to be able to show this to us. Um, so my last question will be, whew, there's so many good ones. I don't know what to do. Let's do a general one. How much No, I don't want to do that one. What are some of the biggest contributors to lack of improvement during the rehabilitation of a patient's sleep? Maybe you
Uh,
already touched a little bit on that.
yeah, can you repeat the beginning, please?
Uhum. Quais são as maiores causas que um
Uh-huh.
paciente, a reabilitação do paciente no sono não tem sucesso, não melhora?
The lack. I didn't.
What are the biggest contributors to
Yeah.
lack of improvement?
I think that our first issue is wrong diagnosis. So many times the patient tries hard to do, and just between us, don't tell anybody, okay? But doing exercises is so boring. If a
It's true.
therapist, yeah, if a therapist are very excited and very empolgada, how do you say?
Uh-huh.
Try
Excited is the same word.
excited therapist. Of course, it's necessary. Okay, we have to be like that. But even that, doing exercises, specific exercises, some of them could sound so your neighbor can hear you doing that. And you have to do a lot, but not uh, 30 exercises. You have to do uh, small doses many times a day. Why? Because these muscles are very small. They are very thin. They can be tired. It's not tired, but
Fadiga?
yeah, it can
Fadigar.
fatigate soon.
That
So you
yeah, so
have
it's
to
get
work.
tired. Like,
Yeah, fatigue.
yeah,
You should
fatigue.
work with small doses and many times a day. So
Mhm.
if a very excited therapist tells me to do that, I have no time. Maybe of course at the first month, the second month, it should be very interesting because it's new, but it's very difficult to maintain the adherence of the patient. And when, in my opinion, the best thing to make them excited and to make them doing is show the results. So in my clinic, we do a very big, complete evaluation. It takes at least 1 hour and a half, generally 2 hours. And after 6 therapy sections, we do everything again. So 1 month and a half later, the patient we are going to show the patient what changed. And then I think that can make him happy and able to continue, because if the exercises, if the functionality works for sleep apnea, the patient has to continue doing that. When the patient can stop, at the same day that he can stop brushing his teeth. Okay, that's what I tell to the patient. Well, I have to do this forever? No. The day that you can stop brushing your teeth, you can stop doing exercise. And you can stop thinking about your chewing pattern. And then you can stop thinking about your swallowing pattern. And then, okay, probably you die.
Wow.
Because when it's forever. So I think that OMT can help a lot the adherence to the other treatments, like mandibular device appliance, advanced mandibular appliance.
Yeah.
I am sure, because I work with this for 35 years, that our work can help the rehabilitation of orthodontic surgery and soft tissue surgery, because many times there is no obstructions, but the patient doesn't know how to breathe through the nose awake and sleeping. So it's very important. And just OMT, we need a very rigor, a lot of rigor. We have to pay attention to the eligibility criteria to do OMT. So if the patient has a moderate or mild apnea, but the parameters about the saturation, the oxymoglobin saturation, nowadays I think that they are more important than that. You have to see if the patient has no other reason to arousals, and the most frequent ones are the movement disorders of sleep, like moving the legs, like Brooke says, and it can produce arousal as well as snore and apnea. So you have to do a very correct diagnosis.
Amazing. Very good. And now, first, Dr. Esther, it has been a pleasure having you here. You're always welcome back at Airway Circle. I know people have questions, but we're not going to have time to do them. We're going to be respectful of your time. I know it took us a little bit to start tonight. But I do hope that we will find future opportunities for us over here to keep learning from you guys from Brazil. And I do believe that Airway Circle is going to be that bridge. So I'm very excited about it. And Anne said, thank you so much. We hope you'll come back again. Any last words before we do our raffle?
Okay,
everybody ready then? All right, let's put the comments on here. Our Airway Circle robe that I posted today goes to Raising Them Kindly. Congratulations, you are the winner. send me your address and I'll send that over to you as soon as I can. But that is it. This week, we have some amazing speakers coming up for you guys. We'll keep y'all updated. If you're not part of our Airway Circle closed Facebook group for professionals, please join us. We're always posting questions and research and whatever else over there. It's a great, tight, neat group. And our directory is growing and it is beautiful. And every day we have people asking, can I please have, a provider in this place or that place? And what type of provider? We have physical therapists, occupational therapists, speech pathologists, myofunctional therapists, dentists, IBCLCs. We have gentle sleep coach, breath practitioners, chiropractors. So we have this group of providers that all can work together in our Airway Circle. It's a free directory and it's an international directory. So even if you're not in the United States, please join us. Anyways, this is Renata and I'm done speaking. You guys have been wonderful. Thank you so much.
I'd like to thank you. I'd like to thank you for being here, and it's really a pleasure to discuss this kind of problems with you, and maybe we can do it again, not only with me talking, but maybe we can share our work and our ideas. Okay, thank you so much, Renata.
Oh, you're so welcome. By the way, did you guys see how you say my name in Portuguese? That's how you say my name. This is beautiful. Yes, Renata. Thank you guys so much. This has been wonderful and much needed conversation. Right? Thank y'all. Bye-bye, everybody.